Thanks, Dr. Sondak. So, in the next 15 minutes or so, my plan is to talk to you all about the management of cutaneous squamous cell carcinoma, or SCC. First, what we're going to do is we're going to break it up into what's really considered low and high risk lesions, because the treatment starts to differ when you talk about low and high risk lesions. And one might be able to make a case for a more aggressive approach with higher risk lesions, maybe wider margins, the addition of radiation after surgery, maybe adding some nodal lymph node evaluation, and, you know, in the future, possibly even some adjuvant post-surgery systemic immunotherapy to help prevent it from coming back. So as you probably know, and we've talked about it before, is that the AJCC, which is our staging manual, does stage squamous cell carcinoma in terms of tumor depth and size. And as the tumor gets bigger, the T category, or the tumor stage, gets a higher stage. And then you have other staging definitions like N and M, where there are nodal metastases and distant metastases. So you'll see a theme here. The higher the T stage, and if we have any nodal or distant metastases, means that we're starting to look at higher risk, and obviously very high risk and or spread of disease. So here's another chart from the NCCN, our National Comprehensive Cancer Network guidelines, which again breaks down low and high risk squamous cell carcinomas. So the low risk is what you would think. It's well defined. It's not recurrent, meaning you haven't treated it previously or haven't had it treated previously or had radiation to it. It is well or moderately differentiated, which means how ugly it looks under the microscope, with well differentiated, looking more like normal skin or towards the normal skin spectrum, and poorly differentiated, where you see on the right-hand side of your screen, sometimes even confuses the dermatopathologist, not Dr. Sai, but other dermatopathologists, as to what we could be dealing with. So the first thing is to work up the patient with a complete history and physical. Make sure you do a complete skin exam. If the diagnosis is low risk or high risk, then we can start to diverge our treatment for the primary tumor. And with low risks, there are a couple different treatments that we can do. We can do curettage and electrodesiccation, or ED&C. And this wouldn't include terminal hair-bearing areas such as the scalp, the pubic region, axillary regions, beard area in men. And if the tumor does not appear to be confined to the skin, really we should go to surgical resection. Or what we usually do is a standard excision with about 4 millimeter margins. You can also do Mohs surgery, where you get that done by a Mohs surgeon, usually in the dermatologist's office, that decreases the amount of skin that we take. They take a sample, they look at it right away. They see if the margins are involved, and they come back and continue to take samples wider and wider around the lesion until they have negative margins. And that's a way to conserve skin around the lesions. And it's well suited for areas in the head and neck and face where obviously cosmesis is a concern, and we want to take less normal skin than more. So low risk squamous cell carcinomas, those are the small ones, the well differentiated. They are not attracted or invading down a nerve. The patient themselves doesn't have any immunosuppression, HIV, Hep C transplant, or other immunosuppressive disorders like being on steroids for immune-mediated diseases, and that it's not a recurrent tumor. And again, those treatment options are listed on the screen. And usually the overwhelming vast majority of squamous cell carcinoma patients fall into this category, and they're easily cured with simple techniques. But when we go to high-risk squamous cell carcinoma, now we're talking about those patients that are immunosuppressed, that have recurrent squamous cell carcinomas, that have big ones that invade deeper into the skin. Here we're talking about more radical surgeries, possibly starting to look at lymph nodes and see if the lymph nodes are involved either by non-invasive methods such as ultrasound, which we use a lot of, and in some rare cases, maybe surgically assessing the lymph nodes with something called the sentinel lymph node biopsy. And then for these patients, we add in oftentimes radiation after surgery. And sometimes these patients actually have radiation or systemic therapy before surgery called neoadjuvant therapy. And we're going to talk about that at the end of this talk. So these are high-risk features, recurrent, involving nerves in immunosuppressed population, in a previously irradiated field, those tumors that look really ugly under the microscope, large size, deep invasion. So what do we do with these tumors? Well, again, we can use some of the techniques that I already discussed. Mohs surgery for some of them, surgical excision. Maybe now we use wider margins than just 4 millimeters. Adjuvant radiation, you can consider some sort of nodal observation, which could be via ultrasound, and in rare cases, in some cases, consider sentinel lymph node biopsy. You might want to image the patients, meaning cross-sectional imaging, which is CT scans. At some point, hopefully in the future, we will have adjuvant systemic therapies to help prevent these tumors from coming back. And we certainly can consider neoadjuvant therapies where we give therapy upfront to help downsize and maybe downstage some of these tumors. So sentinel lymph node biopsy is a way of mapping out the lymph node that drains that area of skin. So for instance, if you have a melanoma on your forearm, we inject a little radioactive dye in a blue dye, and that will hone in on a lymph node that drains that area of skin on your forearm, squamous cell carcinoma or melanoma or Merkel cell carcinoma. And we can take out that lymph node using a very small incision and see if the tumor has moved from the primary area to the regional lymph node basins. And we really don't use this for the overwhelming vast majority of squamous cell carcinomas, but it is considered in some patients with very ugly looking tumors, recurrent tumors, large tumors. And the reason why we do sentinel lymph node biopsies sometimes in these patients is to avoid a situation, as you see on your screen, where the patient had a squamous cell carcinoma on their wrist, and it was a big, ugly squamous cell carcinoma and eventually recurred in the lymph nodes near their elbow basin. So the benefits of sentinel lymph node biopsy is that we can really pick up these nodal basins and nodal metastases when they're microscopic. It takes the guesswork out of the picture, and we can sample them with very minor surgeries. Again, we don't use this very often in the majority of squamous cell carcinoma patients. And as I think Dr. Sondak mentioned before, we are close to 2 million patients with squamous cell carcinoma in the United States per year. So when we talk about who's at risk for these lymph node metastases, it's really rare. There's probably around 5,000 cases of lymph node metastases from squamous cell carcinoma in the entire United States per year. So you would be doing a ton of sentinel lymph node biopsies for a very small amount of gain, which is why we really don't use it in the majority of patients. But it might be considered in patients with poorly differentiated tumors, lymphovascular invasion where the tumor has already gained access into the lymphatics, recurrent tumors, tumors that are in immunosuppressed patients, large tumors in an irradiated field, or oftentimes multiple of these factors kind of clue us into maybe using sentinel lymph node biopsy. So when we look at some of the tumors that I've done a sentinel lymph node biopsy on in the past, some of these are shown on your screen, these large recurrent tumors where they're poorly differentiated and the patient had some risk of spread to the lymph nodes. This gentleman here had squamous cell carcinoma that was already invading some of his muscle. It had neurotropic, meaning invading the nerves. It had lymphovascular invasion, already gained access to the lymph node, the draining lymphatics, and he did have positive nodes. And the same thing with this gentleman who had a very large squamous cell carcinoma on the hand that was invading between the metacarpals or the bones of your hand. Poorly differentiated, large tumor, lymphovascular invasion, another poorly differentiated tumor on the wrist with the lymph nodes that you can see on the patient's arm. This is the two lymph nodes that were removed from the patient's armpit. So my experience at Moffitt I probably see 3 or so squamous cell carcinomas a month. And remember, we don't see the vast majority of these easily treated, very small squamous cell carcinomas, which are easily treated in the dermatologist's office. In our practice, we do see some of those, but we see these ones that are in these higher risk patients for the most part, and that need our expertise, our multidisciplinary expertise at Moffitt. So these are bulky squamous cell carcinomas, like I just showed you. And only one patient had a positive sentinel lymph node. And now this slide should be updated, ending 17 years. And this was in a 50-year-old gentleman who had a poorly differentiated squamous cell carcinoma. He had a recurrent tumor after 3 previous resections and had lymphovascular and neurotropic invasions. Oftentimes, we use alternatives to an invasive sentinel lymph node biopsy, such as CT or ultrasounds. We can detect metastases at an early stage. We can do these 2 or 3 times a year, every 4 to 6 months in high-risk patients. It avoids the sentinel lymph node biopsy. They're non-invasive. It's been proven effective in numerous melanoma studies from our group and groups in Germany and Australia. And then there are even further tests that we're not going to get into today of using gene expression profiling to potentially identify patients who are higher risk for distant and regional spread. And that might be able to help streamline our cases where we would do a sentinel lymph node biopsy. What happens in those patients that do have positive nodal disease? And I said, 1 to 2% of those 2 million cases a year are going to have lymph nodes. Well, they have a lot of options. And most of those options we employ at Moffitt, actually all the options. We use neoadjuvant therapy, usually in the form of immunotherapy for squamous cell carcinoma, sometimes chemotherapy or monoclonal antibodies, or what I would consider targeted therapy for squamous cell carcinoma. They can undergo surgery to take out the lymph nodes, radiation, and most commonly combinations of all the above. In terms of systemic therapy, neoadjuvant is before surgery. The purpose of that neoadjuvant therapy is to shrink down the tumor, treat the regional lymph nodes, hopefully give the patient a greater chance of not having a recurrence in the future. And we use a lot of immunotherapy, cemiplimab and pembrolizumab for that neoadjuvant approaches on clinical trial. We've been participating on numerous clinical trials. And other times we use a monoclonal antibody called cetuximab, or more targeted against a growth factor in the squamous cell carcinoma. So cetuximab has been used with very good success. And you can see here, this is a small study with unresectable cutaneous squamous cell carcinomas, received 6 weeks of this monoclonal antibody. And you can see 28% of them had a response. Another 42% or almost 70% in total had stable disease or disease controlled rate, or disease control. So you're talking about 70% of the patients had disease control. And that's not the best therapy that I think we have out there. I think our anti-PD-1 immunotherapies are better than our cetuximab, and in my opinion, are our go-to for these patients that either need neoadjuvant or systemic therapy because they have had recurrent or unresectable or even resectable disease, where we can give some systemic therapy to help decrease the size of the lesion and hopefully give them some extra benefit of not recurring in the future after surgery. And here you can see 3 different dosings and approaches for metastatic, locally advanced, and 2 different dosings, for metastatic, where we have excellent responses in these patients with median progression-free survivals being almost 3 to 4 years in these patients before half the patients are going to have progression or recurrence of their disease. What about the specific population in immunosuppressed population? So these are patients who have transplants, HIV that's not necessarily controlled, Hep C, and other types of immunosuppression, high-dose steroids because they have ulcerative colitis or Crohn's disease or rheumatoid arthritis. All these patients are somewhat immunosuppressed. Skin is the most common site of malignancy in transplant patients and this immunosuppressed population. It's more common than in a non-immunosuppressed population. And you can see if you're competent, you do better than the immunocompromised patients. However, these immunocompromised patients with the appropriate therapy, including surgery, radiation, maybe not immunotherapy, but we're looking into that, and other types of systemic therapy still have a pretty good disease-free survival and disease-specific survival, although not as good as if you weren't immunocompromised. So what about the treatment of these solid organ transplants? The worry is you give this immunotherapy, the cemiplimab or pembrolizumab, or these anti-PD-1 therapies. The really use of it is limited in the solid organ transplant population because we don't want to risk rejecting the organ. Can we use it in other immunocompromised patients? Maybe. And I know this is being actively studied, including using it in organ transplant patients and trying to play with their anti-rejection drugs to see if we can have a nice balance of giving an immunotherapy while not rejecting their solid organ. And it's definitely considered sometimes at Moffitt at a case-by-case basis. So there's been numerous studies in squamous cell carcinoma using systemic therapy. Here's a study in the neoadjuvant setting where we gave anti-PD-1 immunotherapy in the form of cemiplimab and saw how the patients did after we took their tumors out. So neoadjuvant means we are going to take their tumors out anyway. They are resectable. And did it kill the tumor? Well, here in 40% of the patients, they had a path CR, meaning no viable tumor seen. And another 50% of the patients, another 12% of the patients, they had a major path response, meaning that the tumor was mostly necrotic with a very small amount of viable cells for a combined major pathologic or complete response of over 60%. So we know that anti-PD-1 immunotherapy in this population works. When you look at this type of plot that's on your screen, and I just have one or two more slides, everything that's a downward reflection of a line means that their tumor responded on imaging. So it went from 10 centimeters to 9 centimeters. That's a response. It doesn't necessarily mean it's going to be minus 20 or minus 40. But as it responds more and more, the tumor volume is denoted by this waterfall plot in a negative deflection. And all the lines in green are path CR, meaning the patients had no viable tumor at surgery, despite whether or not they had 100% reduction of their tumor, or in some patients, 50%, 20%, and even 10%. The tumor might have shrunk, but it's all dead if it's a dark green line. So you can see here, versus the patients that had progressive disease, obviously the patients that respond both on imaging and on path review are pretty impressive using this systemic immunotherapy. And here are just a couple of examples of patients published on this clinical trial by members of our group as well. You can see the patient's scan on the top where there's tumor invading the orbit, and that's getting better on the upper right side. Then when we look at the images, the pictures, the clinical pictures of that patient, you can see the clinical benefit after receiving immunotherapy. And another patient down below, after 4 doses of cemiplimab or that anti-PD-1 immunotherapy for squamous cell carcinoma of the right supraorbital area and right forehead. So in summary, very common tumor, not as common as basal cell carcinoma, which again is the most common tumor in humans, but this is a very close second. Most cases, the vast majority, are easily treatable and low risk. Numerous treatments are available. They're all efficacious. You can get those in major cancer centers. You can get those at most of the time at your dermatologist's office in the community. High-risk lesions probably need multidisciplinary care and are best served at a cancer center like Moffitt, where you can have all members of our team, surgery, radiation, medicine, pathology, dermatology, all see the patient and weigh in on the multidisciplinary care, where we're going to combine numerous therapies, upfront systemic therapy, followed by surgery, which might be followed by radiation, or different combinations of that, but definitely through a multidisciplinary approach. And with that, I thank you for your attention, and I will turn it back to Dr. Sondak for the next talk.